Thank you for joining the Perinatal Core Competencies and Decision Support Tools Updated for RNs acting within autonomous scope of practice. Today we'll be looking at the general core competency document and then the general changes to the decision support tools. However, I'll be highlighting the postpartum hemorrhage decision support tool as there's been many key practice changes in this area. My name is Michelle Delany, and I am the Provincial Lead for Perinatal Care at PSBC. I'd just like to start today's update in a good way by acknowledging with gratitude that Perinatal Services BC resides on the traditional, ancestral, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. And I give thanks as an occupier for the opportunity to work and support care here. I also just want to acknowledge that I am remotely presenting, and I live in the traditional and unceded territory of the Sunamo peoples. I also recognize that there are people listening today from other First Nations lands. The Perinatal Core Competencies is in its third edition and has been revised this year, previously to a second edition in 2011 and the first edition in 2009. The look and the use of the documents are similar across all editions. The Registered Nurses and Nurse Practitioners Regulation under the Health Professions Act sets out the scope of practice for registered nurses and nurse practitioners in British Columbia. The following core competencies are set for restricted activities that do not require an order in Section 6 of the Health Professions Act. BC College of Nurses and Midwives has further set limits and conditions on these restricted activities, requiring that RNs who manage labor in an institutional setting must demonstrate the competencies and follow decision support tools established by Perinatal Services BC. These documents will support local education and training. However, they do not replace specialty perinatal education and training. The documents cover a wide range of perinatal competencies, skills, and clinical tools for managing labor, as well as recognizing and managing urgent and emergent conditions. Some of the content reflects RNs acting within autonomous scope of practice, but you may also see clinical practices mentioned that are out of RN scope to support timely communication with the primary care provider, and where RNs will anticipate further orders based on their clinical assessment. Clinical care guidance on specific perinatal topics are linked in the document and also found on the PSBC Perinatal and Newborn Health Hub. There's been a few general changes to all of the documents. First of all, you'll notice that they have been aligned with current terminology and standards for BCCNM. And so previously in other editions, you may have seen RN-initiated activities, and this terminology has been shifted to RNs acting within autonomous scope of practice. There is also an emphasis on commitment to reconciliation with Indigenous peoples throughout their perinatal journey. There's also an emphasis on physiologic labor and birth throughout all of the documents. As well as all of the documents have been updated to current fetal health surveillance guidelines and have included fetal health surveillance as an education standard of practice in BC to be completed every 2 years. The documents are also aligned with the clinical practices and mentioned in the Health Hub, and the updated links have been provided for you. We also know since the previous editions that electronic documentation systems have now been implemented in many areas, and so we have included electronic versions into the documentation sections of the DSTs. The Perinatal Core Competency main document is supported by the 10 decision support tools. this main document applies equally to all RNs in BC who care for birthing people in labors at facilities that offer designated obstetrical services. However, we know that birth does happen in other areas unexpectedly, and so for rural facilities, the core competencies and decision support tools will support them to offer the safest care possible given the circumstances and one's level of competence with labor and birth. Some of the key assumptions highlighted are support for RNs engaging in shared decision-making processes with birthing people, empowering women and people to be their primary decision makers for their care, and supporting informed decision-making throughout the birthing person's journey through pregnancy, labor, birth, and the postpartum period. There's also support for physiologic labor and birth. And labor and birth are physiologic processes for healthy childbearing and should be protected, promoted, and supported by all healthcare providers. Healthcare providers and nurses can support physiologic hormonal pathways by creating an environment where the woman and person feels safe, supported, and comforted. And when physical, psychosocial, and emotional and spiritual needs are attended to, the birthing person may experience less stress and anxiety, supporting those neurophysiological and hormonal mechanisms of labor and birth. The core competencies also support the minimum nurse-patient ratio of 1-to-1 care from a trained perinatal registered nurse, and this means that the RN provides continuous supportive care for the birthing person and their fetus or newborn from the active first stage to at least the first 2 hours of the fourth stage of labor, or until physiologic stability has been achieved. The other piece is we have identified those core educational programs, fetal health surveillance and NRP, which are standards for education standards of practice in BC to be completed every 2 years. These perinatal core competencies will guide the registered nurse and nurse practitioners for the care of women and people during labor within the same framework as previous editions of assessment, organization, coordination, and provision of care, communication and documentation, and urgent and emergent maternal, fetal, and newborn conditions, focusing on that well newborn. The core competencies are recommended to provide a foundational framework for nurses, nurse practitioners, and nurse educators for supporting continuing professional development, and are useful for all perinatal nurses, whether they are novice or an experienced healthcare professional. There are updates to this framework, as I mentioned, to the language and terminology, really emphasizing that whole clinical picture, including the physical, psychosocial, emotional, and spiritual aspects of care, and supporting perinatal care through a lens of cultural safety, humility, and cultural agility, which is the ability to work respectfully, knowledgeably, and effectively with Indigenous peoples by noticing and readily adapting to cultural uniqueness in order to create a sense of safety for all. The Assessment in Labor and Birth section is a clinical tool that outlines the initial and ongoing nursing assessments and interventions required to care for a birthing person and their fetus or newborn without risk factors during the first, second, third, and fourth stage of labor. The components of this initial section includes obtaining a medical, obstetrical, and pregnancy history, physical and psychosocial assessment, emphasizing a supportive birthing environment, and team communication, and then documentation. This section, you will also find mention of the decision support tool resources that an RN may want to refer to if it's applicable to the individual birthing person's clinical context. The 10 decision support tools are highly linked throughout the documents. There have been some minor changes to DST 4, or title changes to DST 4 and 5, 4 being previously evaluation of progress of labor dystocia and has now been changed to promotion of labor progress and response to labor dystocia, as well as DST 5, which really focused on previously on discomfort and pain in labor, and we've shifted it to a much more strength-based approach of comfort and coping during labor and birth. You'll also notice that the numbering system has changed slightly. So DST 8 is obstetrical emergencies core prolapse was previously 8A, and DST 9, which is currently shoulder dystocia, was previously 8B. But we wanted to highlight that all of these obstetrical emergencies may happen on their own and can be on an individual context. The beginning of each DST starts with a table that outlines the connection of the DST to the Registered Nurses and Nurse Practitioner Regulation. Then it follows suit of what indications for use for the DST, followed by related resources, policies, and standards with the associated links. Then there's a definition section and abbreviation section. In some DSTs, this introduction section may be followed by an assumptions or key principles or framework, which outlines some of the physiologic components for understanding the content, principles, and conceptual frameworks in the DST. For example, the DST-5, Comfort and Coping During Labor and Birth, contains an assumptions and key principles section related to the physiologic basis for pain and its role in childbirth, pain experiences, and supportive foundational components to comfort and coping. The subsequent sections remain the same throughout the decision support tools and follow the sections of assessment, nursing diagnosis, special considerations and precautions, interventions, intended clinical outcomes, patient education, and then documentation. Many of the decision support tools have appendices with guides for clinical care, and this may be in the form of algorithms, clinical tools, or tables. Some have added some definitions. For example, in this one, the green box on the top right is the definition of active labor. And so there also, you'll find prompts of when to notify the primary care provider and or MRP, and then when to document and which forms to use based on the paper-based form titles. And so now I just want to highlight some of the key practice changes specifically to DST-7, the postpartum hemorrhage decision support tool. So the key references for this PPH decision support tool include SOGC guideline number 431, the postpartum hemorrhage and hemorrhagic shock, and then BC Women's Hospital in their postpartum hemorrhage and massive hemorrhage protocol that was released earlier in 2024. I also want to note that some of the key practice changes on oxytocin is related to an ISMP medication safety alert that was released in 2022. And then this topic, or this DST, will align very closely with the new PSBC hub topic postpartum hemorrhage prevention and management. New to the postpartum hemorrhage decision support tool is the introduction of the systematic framework of the 6 R's for prevention treatment of PPH that was recommended by the SOGC Clinical Practice Guideline. And this includes systematically looking at a risk assessment, risk reduction, recognizing postpartum hemorrhage, reacting and resuscitating with reevaluation and review. Prevention and treatment of postpartum hemorrhage requires an interdisciplinary approach, timely identification, clear and effective communication, and prompt interventions and teamwork in this systematic approach. The primary goal is really to proactively prevent blood loss, identify risk factors for PPH, and when PPH occurs, being able to quickly identify and correct the source of blood loss, restore the blood volume, and hemodynamically stabilize vital signs and the level of consciousness of the woman or person. Another key practice recommendation is that all birthing units have a postpartum hemorrhage cart that is immediately available with all of the necessary equipment to manage a PPH. And so in section 10 of the DST-7 in the appendix, G, there is a recommended content table of the PPH cart or box, and this has also been uploaded as a clinical tool on the PSBC hub. Another key practice change is really emphasizing that risk assessment and risk reduction for PPH. And so this falls very closely with an emphasis on the interdisciplinary approach to PPH management. We've also highlighted an emphasis on physiologic and psychophysiologic care as a key foundational step to the prevention of PPH or a risk reduction strategy. And so this may be offering a very supportive birth environment where the person feels safe, and that we create an environment of safety, that we are working with the birthing person in a trauma-informed way, that we have a welcoming and affirming environment. And it can also mean promoting and ensuring that skin-to-skin is done early and that there is early breastfeeding and chest feeding. The PPH risk assessment is based on the 4 T's of tone, tissue, trauma, and thrombin. And there is a new clinical tool available that identifies the risk factors and then how to determine a risk level. So once there's an individual assessment of risk factors for PPH, it'll be really important to determine the birthing person's risk level and to identify individuals who may require increased surveillance for hemorrhage and plan their care accordingly. So a risk level assessment should occur of pre-existing antepartum and intrapartum risk factors prior to birth, but then also being reevaluating as they enter that second stage and as their clinical context may have changed, and then again looking for additional birth and ongoing postpartum risk factors that should be assessed after birth as they enter into the postpartum period. And so this risk level can be documented on the BC Labour Partogram under the risk concerns section in section 2 of the front page of the partogram, as well as the electronic documentation systems. Another key practice change in the risk assessment, risk reduction, is determining a birthing person's maximum allowable blood loss. So the maximum allowable blood loss, or MABLE table, offers a guide to the amount of blood loss tolerable before a blood transfusion may be indicated. So there is a rather long calculation offered through the SOGC clinical practice guideline, the postpartum hemorrhage and hemorrhagic shock. However, BC Women's has put together this lovely clinical tool that makes it easier to determine if a person's maximum allowable blood loss, rather than using that longer calculation. And so the calculation is done for you. And so to determine the person's MABLE, you will also need to know the birthing person's weight upon admission and hemoglobin. And if the admission weight is not possible, whether either a birthing person declines an admission weight, or if the person arrives with an imminent birth occurring, or there's some other complication requiring immediate emergent attention, you may want to use the birthing person's reported estimated weight or the last documented weight from the antenatal record. However, this is recommended to be the exception, not the rule. It will be important to assess all of the birthing person's risk factors for postpartum hemorrhage and keep those in mind in their overall clinical picture. Document the antenatal, interpartum, and birth risk factors along with the person's risk level and the maximum allowable blood loss. So prophylactic uterotonics administered for the active management of the third stage of labor is recommended to be offered to all women and people regardless of their PPH risk level. So it is important to note that RNs require an order to administer uterotonics for the prevention of PPH. Ideally, before labor, a shared decision-making conversation should have occurred between the primary healthcare provider and the birthing person regarding the recommendations of uterotonics for third stage of labor, the benefits and risks of both physiologic management of third stage and active management of third stage, their individual risk factors for PPH, and ways that healthcare providers can also support the physiologic processes and hormonal pathways to prevent postpartum hemorrhage, such as skin-to-skin contact immediately after birth and early breastfeeding or chest feeding. Uterotonics for active management of labor are now separated by risk levels. So for low-risk vaginal births, we are continuing to offer oxytocin 10 international units IM, and this has been unchanged from previous editions. However, you'll notice for medium risk and high risk that carbetocin 100 micrograms IM is offered, noting that if carbetocin is not available in your facility, that oxytocin is an alternate choice. For C-sections, carbetocin is the preferred uterotonic for all risk levels, and it is administered IV by the anesthetist. And so the difference in the vaginal birth is that prophylaxis at birth is administered by an RN with an order or a registered midwife. And at the bottom of the chart, you'll notice that there's a caution statement. So IM carbetocin is the preferred route of administration in vaginal birth, so the medium and high risk level, due to the potential risk of retained placenta with IV carbetocin, which you'll notice is a difference in the cesarean birth. At the back of the decision support tool, there's some algorithms to guide the nurse and other healthcare professional in PPH prevention, including risk assessment, risk reduction, as well as the treatment and management of postpartum hemorrhage. Uterine atony is the most common cause of postpartum hemorrhage after the placenta has delivered. So RNs should assess uterine tone. Abdominal bimanual uterine massage is within the RN scope of practice and recommended as an initial basic maneuver in the treatment of uterine atony. This is a skill that should be learned, practiced, and incorporated into site education programs. It has been found that blood loss as well is inaccurately assessed when estimated, even by experienced providers. So some studies have found that healthcare providers tend to underestimate the volume of postpartum blood loss by about 30%. And so a cumulative quantitative blood loss measurement is recommended, especially when blood loss is observed to be more than expected. Obtaining these measurements is achieved by weighing the blood-soaked item and then subtracting the dry weights of the drapes, the pads, and other soaker sheets. It is helpful to have a list in your facility of dry weights, perhaps storing this list in your PPH cart or box for easy reference. This table also offers signs and symptoms that one may see progressively in each of the stages. However, it's important to remember that signs and symptoms may not always be present, or they may occur later in the progression of a PPH. So do not delay appropriate intervention and timely communication with the primary care healthcare provider or MRP when a PPH is suspected with increased blood loss or a quantifiable blood loss that is above what is expected, even in the absence of signs and symptoms. Understanding the stage of PPH may also be helpful to utilize resources wisely in your facility and may help when needed to identify that stage of PPH progress to ensure that you have the people there to help with the management. So this may be obstetrical providers, anesthesiologists, lab, and other team members. All birthing sites are recommended to know when, how, and who to call in their facility. Sites with limited resources or providers who may not be in-house, they may initiate a code call or an emergency response earlier than other areas that may be very well resourced. And so that initial call for help may occur like in stage 1 or stage 2, and it's really important to discuss these details among your team. We also know that a full bladder can impair the uterus's ability to contract and lead to uterine atony. So this is included early in the decision support tool under Recognize, as it's so important to proactively encourage early and regular voiding in the immediate postpartum period. Emptying the bladder is also one of the most critical steps in PPH treatment that should not be missed. And so key practice changes under the REACT and resuscitation is first to call for help. So you will need extra hands to manage a PPH. A coordinated team response is critical to the management. So consider the birth environment as well, the physical, psychosocial, emotional support to promote physiological hormone pathways that may help reduce the blood loss. And aim to address the cause if it's known and restore that blood loss. That means assessing the fundus, the blood flow, and the bladder, and initiating IV access with a large bore catheter. Next, the RN acting within autonomous scope of practice for uterine atony would be doing the abdominal bimanual massage, but there may be another person or a primary nurse that will be initiating an oxytocin infusion. And so the key change in this is that RNs may autonomously initiate a concentration of oxytocin of 30 international units in 500 mils of normal saline. The dose would be 750 milliunits per minute for 4 minutes, and then 117 milliunits per minute to 250 milliunits per minute IV, and titrated to control the uterine flow, blood flow. So this dose is equivalent to the SOGC recommendation of 3 international units over 4 minutes, and then 7 to 15 international units per hour IV, titrated to control uterine blood flow. It's also noted in the SOGC guidelines that doses above 15 international units per hour, so that's the 250 milliunits per minute, is ineffective after 3 international units has been infused. So that's the 750 milliunits per minute for 4 minutes. So be aware that this initial treatment is likely to be ineffective if carbetocin was given in the last 2 hours. So it's going to be really important for RNs to notify the PCP immediately upon recognizing a PPH so that other pharmacological agents may be ordered if it's not effective. Some other key points on this is recommendation to use the infusion pump. So in a 2022 ISMP report, new best practices were recommended to safeguard against errors with oxytocin use. And so some of the recommendations are that sites have a standardized clinical approach to labor induction and postpartum bleeding. And so that also means that standardizing to a single concentration and bag size for both antepartum or interpartum induction and postpartum oxytocin infusions of 30 units in 500 mils. It's important also to standardize how oxytocin doses, concentration, and rates are expressed. So communicating orders for oxytocin infusions in terms of the dose rate. So that's the milliunits per minute, and align these with the smart infusion pump dose error reduction systems. Is also recommended that oxytocin is in its ready-to-use form, and that it's boldly labeled on both sides of the infusion bag to differentiate between the oxytocin bags from other IV infusions, as well as bringing the oxytocin infusion to the patient's bedside when it is needed. In terms of the RN scope of practice, RNs must have a provider order for all other medications to prevent, so the oxytocin prophylaxis, and treat PPH. And then in Appendix B, you'll also find an algorithm to guide RNs and other healthcare professionals in PPH treatment. So recognizing, reacting, and resuscitating with a reevaluation. And so this is located in the end of the DST, and as well as it is posted on the Perinatal Hub under the clinical tools for a printable version. Like I had said before, strong teamwork and communication is critical to the management of PPH. So teams communicate effectively. You want teams to communicate effectively, timely, and in the same language. So PPH is an unexpected complication in most cases, and this decision support tool highlights the importance of entering a patient safety learning system event to regularly review and track PPHs for system improvements. It is also really important for the interdisciplinary team to learn together and coordinate their response, and this can be done through simulations. After a PPH, it's important to debrief as a team to identify what went well, what could be improved, and other system issues that need to be addressed. So many of the local facilities have debriefing tools already in place that could be used, such as the Take 5 debriefing tool in Morro B, or other structured tools for debriefing. In cases of severe PPH or when the team requests, there may be a request for a more formal structured debrief from a qualified third person. And then the review also means debriefing with the postpartum person and their family, and the RN may be involved with the primary care provider or the MRP in this debrief. So where are you going to find these tools? So to find the core competencies and decision support tools, go to the PSBC Perinatal and Newborn Health Hub, and in the top bar, you will see clinical guidance, and from that drop-down menu, there choose professional resources. This is where you'll find the core competencies posted. And all of the decision support tools under one section. I would like also to mention that you could use the search bar to search for specific, for the core competencies or specific DSTs. All of the tools will be available on the hub in electronic version and also printable. And then some of the clinical tools are listed in the clinical tools section, resource section of the hub, under that professional resource section as well. So there's many ways to get to it, and I just wanted to highlight that. There is a clinical care topic that's being uploaded at the same time of the postpartum hemorrhage prevention and management. Well, thank you for listening today. There is a summary of changes that will accompany the DSTs in a little more detail. And if you have any questions, comments, or feedbacks, please email psbc@phsa.ca or the hub email at hub@phsa.ca. Thank you for listening.